και όχι αυτά.
Το έχεις κάνει.
Επιμέρους και γενικό.
As I said, I was trying to work out who was who and how to structure this, but he said it has to be interactive, otherwise it's not a workshop. So I hope it's sort of practical and you can direct how you want it to be practical. My sort of initial thoughts were to move on from those elements, like your last question about these children and how to work in difficult circumstances, and to look at some very practical issues of assessment, formulating sort of a care plan, and then deciding what type of intervention, but relating it to your role. I'm still, it's a great number here, so I'm into mixed feelings whether it's one group or we split into two. My inclination is to have a large discussion about certain things, and then when we discuss a couple of cases to split. So as I said, my name is Panos. I thought if maybe if we start just to address that question, so it is for all of us to understand different roles. And if you don't work with children or in a particular group that we talk about, it doesn't matter at all because you work with adults, with parents in different sort of capacities, so the issues will not be different. So if you just say a few things about yourself, about your role, it could be in an academic capacity, that's fine, if you research a particular field, or if you work in the field in the past. So it doesn't matter if you cannot ask these two questions. Just to think, what are the particularly difficult things you have found? Okay, I've given hints, but I'd like to hear your evidence working with traumatized children, people, adults. And also, what have you found useful? And maybe a technique, maybe how you work with systems, just this sort of discussion.
Hi, I'm Lina Amiri. I'm from the United Arab Emirates. I work in the United Arab Emirates University, but I'm just about to join the PCRF. I don't know if you know Steve Sosomi. He's involved in working with children in Palestine who have been traumatized and for the effect of war. So the context of the work with them will be them coming to the UAE for medical treatment and then working on their mental health issues as psychiatrists. This is a challenge. It's going to be a challenge for me because we're going to see them from 2 weeks to 3 weeks, 1 month at max. So we need to formulate a way where we can help them most in this short duration of time. So that's why I'm interested to join.
Right, okay. So you have multiple need, okay, you are well placed to do that, but what do you do in that very condensed time?
Yes.
Okay, so that's great, nice challenge to have. A few years ago we didn't.
You didn't?
Well, you were not in that position years ago. It's good to be in that position, to have that challenge. They wouldn't even come close to you.
No.
So, okay, so that's the challenge, obviously. Any thoughts or, well, we can innovate a bit. I'd like to hear other people's thoughts. What are your first thoughts, how you go about it? When you do in 3 or 4 weeks? I mean, it's the difference between mental health. If they were coming for a hip replacement, you change the hip, send them back.
That's it.
So what do you do in?
So we had a meeting first time, and the things that I can propose to them when they ask how I can help, I thought maybe it's working with a teacher or people directly involved who can actually continue to apply whatever we teach them back in Palestine when they return.
Yes.
So I thought this might be the most practical work. And maybe start this kind of play therapy, art therapy with the kids that they can actually go back and teach their other friends, other kids to apply them. I can't think of much. I don't have much experience with trauma children, and this would be my first really direct contact with
Okay.
them. So
But already your first thoughts are to do something, I mean, deliberately vague here, to keep it open really, to help them when they're there, and hopefully take something back for others, but also to strengthen the systems when we go back to have some sustainable.
yes, continuous.
Yes, okay. And it's always the challenge for all of us, is the sustainability.
Yeah.
Okay. Any thoughts to, what's your first name again? Lina?
Lina.
Lina. Any thoughts to Lina? Really interesting, unusual challenges here. What would you advise her?
Are the children coming on their own, or are they coming with a protection figure?
So they're coming, some of them with their parents, if they exist. Some of them don't have parents. They come with what they call social workers, and they're not really social workers. They're or psychologists, are people who work with children, have been working for years. So they're coming with them, and they will be their caretakers. And and they'll be placed in homes of people who are going to volunteer to have them over. And we're going to meet them in the center there. We have like a small space where we can meet them and do the work we need to do. So I still haven't met them yet. It is going to happen within a few months. So I thought maybe I should come prepared, or maybe get some more idea. I'm reading about it, but I'm just.
And so your center is health center, welfare, NGO?
It's a non-profit organization. It's run by this man who was married to this, he's American, Steve Sosobi, you can find him on the internet. He was married to this Palestinian woman who actually was very passionate about this thing. She died of cancer. This inspired him to open a cancer center for children in Palestine and Gaza, and he got it up and running. And now in the sector, they've been approached, but they're not really interested. So,
because I belong in an organization, European Family Therapy Association.
where?
Here in Europe, we are trying to organize this organization and see if we can actually be in touch with other people, you know, from the rest of the Europe, not particularly Europe. I mean,
Yes.
we can actually see if we can expand.
I can take your number and then see if we can
So,
do
yeah,
something.
that would be very interesting.
It would.
Okay, really interesting. I wasn't far from you last week. I was in Iran, which was a different challenge, not far from you here. It was great. Much different than what people think when you get there. Much better.
Yes, they're
All right.
very nice people.
We'll come back to that. How about you?
So I'm Tanya from Germany, but living in Switzerland. So right now I'm doing a PhD, and I'm also a psychotherapist. So I worked more with adults actually, and I always remember my first experience with when I was really starting being a therapist, and I had this young woman who had experienced sexual abuse, and it was very stressful for me because I had always.
What were your worries? What were your worries?
Yes, I was worried.
What did you worry
that she gets re-traumatized,
Yeah,
as I
yeah.
had heard this theory.
Yeah.
And then I decided to make a special training for
Yes.
trauma,
Yes.
which was very helpful, and now I feel much more confident. But still, I think it's always something difficult for me to see, how to handle this, how quick you can go, how much they should tell you about it or not.
Yes.
And this, this is not very easy.
No, it's
for
never
me.
easy. It will never be easy. But what would you think now after your training and that experience? What would you say to others? I mean, I'll tell you what I think, but just how much you've processed it.
So for me, the training was very helpful because now I have a very specific technique I would apply, and this helps me having a frame in which I can work. But then I think with every patient it's so different. And maybe another fear I have is also for myself.
Yes.
Because some stories are so terrible that you don't want to hear them. So I think I have both things.
It's how it impacts on us and also
and
also
how
on
to
people.
protect also yourself
Yes.
as a therapist. So.
Any thoughts on that? I think my thoughts about general, but your thoughts on, first of all, starting with when is a good time to talk and what the pros and cons here. You obviously want to help people, but when is it the right time? Give us maybe an example where it worked, or another example where it was difficult, where people should do.
Well, to my experience, I'm not working with children that much, mostly with
Doesn't matter.
adults with trauma. It's very hard to approach people, especially when they're vulnerable, to when they experience trauma, with regards to the previous trauma that they have, to know how, not to know, you should know that there's so many things to do when they start telling you about the trauma, and that's the hard part. To me, in my service, when I was working.
And you see them in, sorry, I'm jumping a bit, but now it's important. So in what context? Because that's the key. What's your role? Tell us your name and your role.
My name is Christina. I'm a forensic psychologist.
So you see
I work with prisons and probation services in the UK.
So they come for assessment or for therapy?
For
or for
assessment,
both?
mostly therapy for adults, but assessment. But when it comes to children, I have to refer them to a child psychologist
but
or
same
a
issues,
psychologist. of stuff. But I had to deal with trauma with clients when they're coming and they're experiencing different things. So yeah, that's what I found very hard, of how to handle all the emotional pressure, and as a psychologist, and for the people to relieve them. And actually, the only thing I had to do is do nothing and just listen to them. And that's what I found hard, because I like to see working done with these kind of people. And that I find challenging.
Okay, yeah. Well, as I said, it's tough, never gets easy. But at least you have some, as you said, you have a framework, hopefully, over the years. I think, you know, the first question is, that's why I ask you, in what capacity people come to see us, what they know, what they don't know. I mean, at the beginning, particularly with children, I spend most of the time checking what they know about coming, because a lot of the time they just bring them, you have another element there, which makes things hard. And if they're disengaged, I work with offenders. They don't know why they're coming, they think they have to because the courts tell them. So unless you break that, there's no, you can't.
It's not only that, we were supporting family of offenders as well, and that even sometimes the offenders were traumatized, sometimes they were not, but mostly it was the people around them that they will have to support when it comes to trauma.
Yes.
With children involved, or partners involved, or first family, mothers, or that they were experiencing more pain sometimes than the offenders.
Yes.
And especially when there were children involved, and I had a case with unborn children that they were being really mistreated from the offender. So, yeah, I don't know.
So, I mean, there are many strands there, but I mean, okay, coming back to yours, first of all, when is the right time to talk? So, as I said, I mean, at least when they come to me, I mean, people may have different questions. The first is, I try to separate assessment from therapy. I think there is a risk there. Obviously, if you open things up, and then you cannot help them. That's one, that's a clear worry. There is the other risk that if you collude with it, if you pretend it's not there like everybody else does, the child goes away thinking it's okay. I mean, what I try to do is to work before the assessment to get, I mean, these are children care usually, they come to me, so I tend to acknowledge, say, look, for today it is, you know, just to get to know you, see if this is the right place for you to come again. I don't know if we can help you, what do you know about coming here. And if I know something, I will acknowledge without spelling it out, but then to say, well, I know things from your social worker, this is not the place, I was not planning to ask you questions to repeat, because sometimes they get very frustrated, everybody asking the same questions. But if you want to, that's okay, but at least my plan for today was not to do that. I try to separate that from therapy. And as you said, some people do, some don't. Some go so fast, you can't follow them. And then you have to make a judgment, really. If it's not a therapy session, what do you do with them? Because they'll have to be able to process it and be relatively safe. So ideally, I would separate. And if it's for therapy, that's a separate issue. They come back again, and then you have a separate discussion. But you know, human beings are not computers, so they can either not gel with therapy, they're not ready. And if they're not ready, so be it. Or go too fast, but then you have to protect them as well. And that's when you talk about the children yourselves, not about Italy, about the refugee children. Who was talking?
No, there was somebody next to you.
She's gone. That's a challenge about working with, you know, when you draw the boundaries with, I don't mean with no specialists in a derogatory way at all. What I mean is they want to help, and how far do they go? Because a lot of the help is much better. For example, teachers, youth workers, volunteers, they are the only people that the children can talk to. So it can't be the only opportunity to get help. The question for them is, okay, if they open up, what do you do with it? And I think that's a difficult boundary there. So knowing what they don't know is probably more important. The other issue, I don't know what your views were. I mean, I hinted earlier about there was an intervention years ago, which sort of I hinted that it's sort of gone out of fashion. It's not used, called debriefing. What are your views? How do you understand it, and what do you?
It's like after a trauma, they get together and talk about the incident, what happened. They think it's a way to vent.
Yes.
And maybe feel better afterwards, but it's actually causing exactly what she's talking about.
Yes.
Putting it out there and no closure, no kind of...
Yes, it is more, I don't know, guided or directed is the right word, but certainly it's active. And there are interventions can be active, but basically you push people to talk, and if they're not ready. So that's why people, I mean, on the whole, therapists were a bit ambivalent, went into fashion. I think it had its use because these were the days that recognizing trauma 10, 15 years ago wasn't as it is now, but probably went too far, and then people attacked. The evidence wasn't very strong. There was some evidence that could make things worse. I don't want to make big statements here, but there were some hints, and on the whole, that approach has evolved, I think, to more reflective, but more a combination, not just waiting, but on the other hand, being more sensitive, as you said. But you have to make a judgment, don't push.
But one of the things
Tell us who you are and what you're doing. It's important, otherwise it becomes boring.
Can I say the point first, because
very good
otherwise
point. You missed the point.
I think the debriefing stuff was quite reductionist as well, because it was often done in group formats, but it assumed everybody had the same coping strategies, and everybody had the same kind of experiences, either pre-trauma or post-trauma, and I think that was a big difficulty. So it opened up a lot for people, but as a mechanism, it wasn't able to contain the situation, because we use it sometimes to support our staff in work, but we do a lot of kind of preparation stuff for that. So my name is Cathal. It's an old Irish name, and I work in Ireland, but I did a lot of training in the UK, and I'm a clinical neuropsychologist, so I look at things very much from a brain function point of view. So I work for an organisation called 3 Steps, and we provide therapeutic assessment and intervention for children in care. So we work with children in residential programs and children in foster placements.
Right.
But we try and make the residential programs as brief as possible.
For staff, you mean, or children, or both?
Children and adolescents.
Could you tell us a bit, it's really interesting how, because I work with them and it's not the easiest group, probably the hardest group. You know, some ideas, you know, what are the difficulties, and, you know, something innovative to have this progress sustained. Obviously you're doing something right.
Yeah, I suppose what we do is we look at things that quite systemically. So we constantly, when we developed the service, we kept looking at attachment theory and focusing on attachment, so that basically from within but also externally we look at who are the attachment figures. So for a child in care in the residential program, they may have had a previous placement with a family member, like an aunt or whatever, so we very much try and identify all of this at the beginning and then focus on that. So we invite them in to attend the therapy sessions, which we do a lot of, and we also integrate therapy with principles of DDP and developmental psychotherapy, because there's a lot of congruence between the two. So if they want to talk, we go down the route of DDP. If they don't want to talk, it'll be more therapy. Looking at it from a behavioural point of view, a lot of the trauma can be kind of come from that social learning perspective, and learned kind of behaviours, but there can be a clear trauma history.
Start again, who does what. And then I had a message just before I left on Monday, a lady from Dancy's home, about another child. I said, oh, who are you? She said, I'm the new manager. I said, what happened to the other one? She's left. So, I mean, I was picking up clearly there was a problem in that home with the staff group. Some staff were telling me the child is good, some were telling me something's not right there. I don't know